Since I started my career in 1971 with Seaburn, so remember it well. Since those days, there's kind of been debates in social care around what prevention, early intervention are, and I think we're still in some of that stage. But probably I've been more confident in the last 2 or 3 years with the growing evidence base that is emerging, and it's emerging partly because we're doing more research, and that's good. Partly because of the evidence comes from places like POPs, from some of the evidence around intermediate care, the work of the Nuffield Trust and the King's Fund, other academics beginning to build an evidence base for us. But within that base, there's still this debate about what is prevention and what is early intervention and what does what when, and a confusion that I hope today will kind of get underneath and begin to sort out.
Interim findings from the national evaluation of the POP pilots indicate that for every £1 spent on a wide spectrum of preventative schemes, there is on average a £1.73p benefit to the health and social care economy. What is important is to be clear about what is being commissioned and why in order to deliver a balanced system, which will make a real difference to the way individuals engage with services and support, and in doing so will make a real difference to their lives.
Savings, reduced demand on hospital bed and residential care bed usage is the gold standard measure of effectiveness in prevention. The problem that I see with this as the universal measure for outcome is that it tends to favour the secondary, tertiary types of prevention, the higher intensity types of prevention, the ones that are very clinically focused.
So what people want in their lives, based on research done by the Older People's Programme, is they want meaningful relationships, personalised support and care, personal identity and self-esteem, home, personal surroundings and possessions, personal authority and control, and meaningful daily and community life. This will happen if people ask. So one thing you take away from today, please ask, listen, respond, act, report back and evaluate.
Maybe the area we should kind of first explore, which is the use of the word prevention itself, prevention, early intervention. What do we mean when professionals and others use the terms prevention, early intervention?
I suppose I would ban the word unless we were very specific, as you to mean, because I think we do all mean different things by it. And I think also it's very important we frame this positively. What are we trying to achieve, which I think some colleagues have said, which actually is healthy, active, independent old age, active citizenship. So that's the goal. You're not going to prevent some of these illnesses, but you're going to prevent the impact of them. But I think we need to frame it positively.
One part of the discussion is those people who don't have carers, who don't have that family to provide that very important role. The second part of the discussion is if families do engage in that care and do help on the prevention agenda, how can they be helped? How can families be helped and supported in a way that helps them? And the third part of the agenda really is looking at those carers themselves in terms of prevention.
There is something around a sense of what we want to achieve here, and it is about inclusivity. It's a deeper issue than saving money, because it's a win-win for all of us if we can achieve that well-being, so that we don't need the services. So something about avoiding services altogether, but maybe that's going a bit far.
When people experience going into hospital, what do they get the right things done? Do they get the things done that could not be done somewhere else? Do they get things done in the right way? Now, we know that acute hospitals are actually, by and large, becoming less fit for their majority users. This is something that could potentially be addressed in the NHS, or at the moment, it's got a relatively low priority in terms of the other priorities in the NHS.
I know this sounds an odd thing to say, but the fitter you are when you go into hospital, even if you have an acute episode, you are actually better equipped to come out earlier and lead more fulfilling lives. It isn't just the packages of care we can give to people, it's the sheer health. And I think those two agendas actually are quite aligned in lessening that need for hospital care.
What we still haven't got a proper measure of is
the impact on older people's quality of life, and we should be able to put a value on that. I don't think that's beyond us. I mean, certainly we do it in other areas of life in terms of cost-benefit analysis. I can't see why we can't do it in this particular area. So the big question is, why isn't this happening? So, I mean, kind of going back to Anne's presentation almost, we've got lots of examples of what could be done. We've got lots of evidence, and the Joseph Rowntree Foundation and the inquiry that Anne referred to in terms of that bit of help tells us what older people want and makes it very straightforward as what needs to be done.
We learn to be children, we learn to be young adults, we learn to start and have a family, but you don't sort of have that bit around the education, around learning to what's the good positive bits about ageing when you get on. You're expected to know it rather than have an opportunity to learn and face the way you want to go forward on that. And I think some of those things then tie into that's where you do see the spirit and the community and come together within projects like some of the initiatives we've had in Linkage Plus.
It seemed to me there were some things that actually community care are given quite a positive spin to that actually I find a bit worrying. So for instance, on the contribution of the NHS to wellbeing, in the sample, it seemed to me that only about 25% or 25% thought that the NHS wasn't contributing very much to the well-being of people in the area. And on safeguarding, about 25% of people felt that local councils weren't being very effective.
What's really required to make this whole agenda much more effective and efficiencies for both health and social care is that the old chestnut of joint working in a mature way, and recognising that there are things that health does which will have a beneficial or negative impact on social care and vice versa. We need to have cards on the table and have these sorts of discussions.
So we're teaching them then that practice your physical hygiene, practice your well-being in whatever you eat in your diet, and so especially people that have diabetes and they are being controlled with food. You don't just put everything in your mouth that won't bite you back. And so we are going on with this kind of teaching care. People want education.
It's inexcusable that local commissioners continue to choose to continue to invest in things where the evidence is weak. It's inexcusable. That's not the best use of public funds. And but what we must do, if we're confident about that infrastructure, is be brave enough to say that infrastructure will be in place irrespective of the personalisation of services, because we believe it is a good part of the infrastructure to be there.
A number of households that used to get domiciliary care in the early 90s, I think from memory, something like 530,000 households, and we're now down to 300,000 households. Now, against that, the number of hours per household was rising, which suggested that home care had gone from a cleaning, shopping, cooking to a personal care service, which is a good thing. But what is difficult to identify is where are the services to do the cooking, cleaning and shopping coming from?
I just wanted to offer a kind of word of warning from some of the research I did last year in the US, where another strategy that they're pursuing is to look at the kinds of patients that they think are going to be the least likely to cooperate with preventive care. And if you look at the kind of list of the conditions and situations that they have, it's a bit of a kind of roll call for the kind of patients that we, in this side of the Atlantic, would want to target extra resources to. So, for example, they'll say, well, people who've got mental health problems, they're going to be really difficult to work with preventively, so we'll kind of abandon them. Anyone who's got an addiction, or a single parent, or somebody who doesn't speak English, or somebody with learning difficulties.
And I think where I hope we've got to is an image of a society where it's good to grow old, and that's what we're trying to create, and making sure we get the right interventions to people at the right time, and the timing has been an issue, so that actually those people who can get the care and support they need at those critical moments, but maybe don't necessarily for everybody sustain long-term support for their care if that is not what is required.